Afternoon, everyone. I am Andy Dwyer, and on behalf of the Fight Colorectal Cancer team, I want to welcome you all to today's webinar, Family First: What You Need to Know About Genetic Testing, Family History, and Colorectal Cancer. And so Heather Hampel will be joining us today as our lead presenter, and so we want to thank Heather for presenting and welcome all of you. So just before we get started, I just wanted to do a quick introduction. I am Andy Dwyer. My formal name is Andrea, and I joined the Fight CRC team just this last month. And I've been connected with Angie, Michael, Danielle, and the team for the last couple of years in a lot of different roles and working in terms of collaboration and colleagues. Here I'm a joint appointment with Fight Colorectal Cancer and the University of Colorado Cancer Center and the Colorado School of Public Health. And so in our collaboration throughout the couple of years, we definitely have had a lot of shared vision and partnership for colorectal screening and a number of initiatives. And I'm happy to join their team working in the area of health promotion and survivorship. So just a huge, huge thanks for all of you for joining, and just amazed at what Fight Colorectal Cancer and the team have been able to accomplish, and I'm very, very excited to be a part of this. So just a quick couple of housekeeping issues. You all are muted, and so if you have questions throughout the presentation, please go ahead and type those in. You actually, by going to GoToMeeting and the webinar function, there's a place for either the chat or question box, and we have those open. And we'll be recording that information and then maybe presenting those questions real time for Heather for us to present. And then there will be a definite time for us to go ahead and move forward in terms of thinking about the questions that come up, and then the time after the webinar for us to really go through questions as well. So just a quick note that we do have a number of archived webinars at our website at fightcolorectalcancer.org, webinars. After our webinar today, there will be actually an email link with a number of the resources that Heather mentioned, as well as several resources that Fight Colorectal Cancer has identified or helped partner relative to family history and the information around gathering information. And we will just, again, remember that on the right side of your screen, that panel is an opportunity for you to type in those real-time questions. And we know that via Twitter chatter today, there's a lot of excitement around this discussion. But just follow us along at Twitter versus a hashtag CRC webinar. And we'll give you some real-time updates, and then we'll continue that linkage as a resource going forward. Just a quick update for this upcoming month is that we will be talking a little bit about the colorectal cancer research and treatment in partnership with a partner, Colon Cancer Alliance, and we're going to be doing that presentation in June at the standard time at 1 o'clock Eastern, 2 Central, 1 Mountain, and 12 Pacific. So we hope that you all will join us today, and I know we've had a really robust response for today in attendance, so we're looking forward to those continued opportunities. I wanted to just say a couple of words about the funding around research and the work that Fight Colorectal Cancer has done. Many of you know about the LISA Fund, which was established in 2006, which has raised hundreds of thousands of dollars for funding in terms of late-stage colorectal cancer research. We just want to encourage you all to think about, for donation, thinking about people and partners who might really be interested in helping us in this combined effort around late-stage treatment, to really think about Lisa's Fund and Fight CRC. I think as several of us have been speaking about, what really makes the Lisa Fund and the monies from this is really that it's a diffused mechanism by which research funds are actually vetted throughout the country, looking at a number of institutions and agencies who are doing things in the development, and that we're really looking at the best and the brightest amongst many, many academic cancer centers, research sites, and the like, and keeping a real-time sense on what's happening. So we're really excited about this opportunity. As you can see, definitely some growth in terms of the amount of money, but this is one of the aims of Fight Colorectal Cancer, is really thinking about advanced and late-stage research and what we can do in development. Just a quick note, of course, is that the information that's actually provided here today is for informational services. It's not to be used in terms of substitute for any direct medical care, medical advice. It's really a supplement in concert with the medical team, your support network. And just a quick note, of course, is that if there's ever any sort of emergent situations or anything that should happen, a 911 or direct response to a healthcare provider is something that we should always be cognizant of. And we, of course, here at Fight CRC never recommend or endorse specific physicians, products, or treatment for any of the conditions. And just a quick note, again, that your medical team and a 911 response is what's needed in terms of a medical emergency. So today we are going to have Heather, who is going to be chatting with us a little bit about the family history and thinking about genetics relative to colorectal cancer and risk. We actually are going to change things up a little bit today. We are actually going to initiate a real-time poll where we will be thinking about, ultimately, we're getting the response from all of you about who's around the table, you know, what are the demographics and the people that are attending these webinars. We want to really hear from you about who you are, information about your diagnosis that might also be relative or helpful in thinking of future initiatives and really getting a good sense of who we're reaching and the programs and materials that we're providing, who it's really helping make the most connection with. And so I just want to actually just tell you, of course, the response to any of these questions are completely anonymous in terms of just getting counts. It's helpful in the planning, but it is completely up to you in terms of the answer or the polling piece. With that, and in terms of thinking about feedback and response, as noted, we will be following up with an email survey about the participation in today's call, your interest in the topic, as well as your satisfaction or any input about materials and information that were provided. And in that time, we will also provide those specific links and informational pieces that Heather presents, again, as well as some Fight CRC specific materials. So with that, before I present Heather, I'm actually going to go ahead and work on the initiation of our poll. And so again, these are going to be just some quick specific questions that we're going to ask. And these are going to be related to age, gender, point in treatment, as well as cancer type. So we'll give about 5 to 10 seconds per question for response. This should take no more than a few minutes, and then we'll actually have Heather move forward with her presentation. The first question that I'm going to ask is actually around is really around specifically questions around the age group. So here we are now. If you can please go ahead and tell us, was everyone able to respond? It looks like we have definitely some response. Okay. All right. And we definitely have some very fantastic age representation right now. The next question that we're going to ask around is specifically looking this here. Okay, just one moment. We are going to be adding in some additional questions, and if we have any technical difficulties, we might come back to this at the close of the presentation. Okay, then at this point, I'd love for you all to provide information about your specific gender. We have age, and we have just providing information about the number of people who are joining who are men or women. Okay, just give a few more seconds. We have about 3/4 of the group who voted. Okay. We're going to ask a few questions about colon cancer and what stage. We have about 3/4 of the group who have voted. Okay. And that was specific to colon cancer. I'm sorry, I should have made that very clear. We're going to ask specifically about rectal cancer. And then the next question is if you've had colorectal, if the ultimately what stage you're in. And which, if you are a colorectal cancer patient or colorectal survivor, which best describes where you are in treatment? And we have about 1/3 of the group who has responded so far. So if you could please submit your final, or for the final question. Okay. So it looks like 1/3 of the group is currently in treatment, about 20% in the last 6 months. About 1/3 of the group has finished in the last 5 years and about 10% in the last year. So thank you all for taking the time to definitely present or provide information for us. And this will be, again, very helpful for us in understanding what information is best and who's actually attending our specific presentations around what materials so we can continue for planning purposes. So with that, I am actually going to provide a quick description or a quick background and bio for Ms. Hampel, and then go ahead and turn off the controls for today's presentation. So Heather received her bachelor's from the Ohio State University in '93 with a specific degree in molecular genetics. She's a certified American board genetic counselor, and she actually has gone through the certification as well as recertification. She currently works for the 2.5 years as a genetic counselor, or she worked as a genetic counselor at Memorial Sloan Kettering in New York, and has worked at the Ohio State University Comprehensive Cancer Center as a genetic counselor since 2005. She's the Associate Director of the Division of Human Genetics in the Department of Internal Medicine. She's been an active participant in the National Society of Genetic Counselors, including co-chairing the 2002 Annual Education Conference on the Education Committee, and an NSG Board Member of Directors on Region 4 representative. She's also an American Board Certified Genetic Counselor, including in counseling, including item writing, the Nominations Committee, and the ABGC Board of Directors as President from 2009 to 2010, and Credentials Committee Chair in the year of 2011. So Heather's been exceptionally busy. She's actually even made time to be on our presentation and webinar today. So with that, Heather, thank you so much for joining. We're very delighted to have an expert such as yourself, and I'm going to go ahead and give you control for today's presentation.
Thanks, Andy. I'm really excited to be here. And as soon as I get control, I'll start forwarding the slides. I do want to mention while we're changing over control, I just want to thank all the people who were publicizing this talk on Twitter. It was going Twitter crazy yesterday and today, and I know it got a lot of publicity through Lynch syndrome channels, and I do want to be clear that the talk was originally targeted towards people who might not know that they have Lynch syndrome yet, and might be collecting family history information and figuring out if it's likely that they have a hereditary cancer syndrome or not. But I think that there's some important things to take away for patients who already know they have Lynch syndrome too, because it's always good to get as much family history information as you can so you can warn your at-risk relatives so that they can also undergo genetic counseling and genetic testing. So I think that this has some applicability even for patients out there who already know that they have a hereditary cancer syndrome. And I am going to go through some details about a couple of the more common hereditary colon cancer syndromes during the talk. So this talk, as you guys know, is Family First. What do you need to know about genetic testing, family history, and colorectal cancer? And I don't see how to advance, Andy.
Here we go. Heather, are you able to advance?
No, I see no button that will allow me to advance. If you need to advance, that's fine. We better get going because I have a lot of content to cover.
Okay, let me try one more time here, and we will, Heather, if you just use the clicker on the slide presentation, it should be able to go.
So I have an arrow.
There you go.
Okay, I don't know what I pressed, but I'll keep pressing in the same place. Okay, so the big take-home message for everybody today is that most colon cancer, most any cancer, is actually not inherited. So if you look at a piece of pie, that represents all cancers, you'll find that in most cases, about 5 to 10% of any given cancer are truly hereditary. So that's due to a single gene mutation or mistake that's running in the family and causing a really high risk for cancer. Then there's this other piece of the pie that's about 10 to 15% that we like to call familial. And when we talk about familial, what we mean is that there's a few more cases in the family than we would expect to see by chance alone, but not a single strong gene mutation running in the family and causing cancer. We have a little ways to go into figuring out the cause of some of these familial cancer families. We always tell our patients that it's probably a combination of things. Minor genes that slightly increase the risk for cancer, plus shared environment. People in the same families tend to live in the same kind of places, eat the same kind of diet, so they're exposed to the same kind of environmental risk factors. And that combination of minor genes plus environment can kind of combine to make one family less likely or more likely to get colon cancer than the next. Then the vast majority of cancer patients do not have a hereditary syndrome. They don't have a familial cluster. They are what we call in genetics sporadic, meaning they've just popped up by chance alone. Age is the greatest risk factor for cancer. As we're getting older, we acquire genetic mistakes in our body, and if any one cell gets enough of them, it'll start growing funny and not die when it should, and it will become a cancer. And these people with a sporadic colon cancer do slightly increase their relatives' risk for getting cancer as well, just because there still may be some shared things in the family making you a little more likely to get colon cancer than the next person. So when you're thinking about, am I or is my family member or my friend likely at high risk for cancer? What do you need to look at to figure out if who out of these hundreds of thousands of people, who are the ones who are at high risk for cancer? And so picking those 3 people out of the crowd is a little tricky. So what we always say in genetics, of course, is family history, family history, family history. It's really the most important first step in risk assessment for all genetic diseases and other hereditary health conditions, not just cancer. This is becoming more and more important. Cardiovascular genetics is really emerging, neurogenetics, risk factors for things like Alzheimer's and Parkinson's disease. And so getting a good family history with health information is critically important first step. Okay, because I can't see the buttons, guys, I don't know when I'm pressing them. Okay, so I occasionally might do it twice. So this, I think I went too far. Let me just see. Am I going forwards or backwards? Andy, can you help?
You look good, Heather. You can use your mouse or your keyboard arrows too, or forward or backwards, but they're moving.
I did not want to move forward 6 slides. I've advanced it, and I can't reverse. The keyboard is not reversing, and I don't see the button for forward and reverse. I have an idea where on the screen to click. Okay, I think that's where I am. Okay, so One of the resources we're going to give you today is the Surgeon General's website for the My Family Health Portrait information. And one of the things they're saying is that family tree has really become the most important genetic test of all. And to really focus attention to that, the U.S. Surgeon General, in cooperation with a lot of other agencies, has launched a national public health campaign called the U.S. Surgeon General's Family History Initiative to encourage all American families to learn more about their family health history. So the website is on the slide, and it'll probably be in the resources at the end as well. I'm going to try and forward one slide. Okay, you might have taken control again, so if you could just forward for me. So they did a survey a couple of years ago, and it's very clear that Americans know that family history is really important to their health. In fact, 96% of Americans believe that knowing their family history is important, but in the same survey, we found that only 1/3 of Americans have actually ever tried to gather and write down their family health history. So while we know it's important, it's something that we just don't take the time to sit down and do. Next slide. And so this is one tool, but we're going to give you lots of tools today, a computerized tool to make it fun and easy for you to create a sophisticated portrait of your family's health. So that's one tool, but we're going to be giving you a lot of them today. Next slide. Also, we want to mention that, of course, Thanksgiving is annual National Family History Day. The idea just being that anytime you've got your whole family together is a great time to bring up this conversation and talk about the family history, write down the health problems that run in the family. And so this season we might be thinking of graduations and weddings and other times that the whole family might be together when you can start to ask this information. At one point, being a genetic counselor, I realized I hadn't sat down with my grandparents and asked them about my family history, and I did, and I'm so glad I did. They've passed away subsequently, and I wouldn't have that information otherwise. My only regret is that I actually didn't tape the interview with them because it was really rich with a lot of family stories and history that, you know, I'm struggling to remember years after I did this interview. And so I would just encourage you to sit down with sort of the oldest family members that you can and record or video your actual interaction as they tell you stories about your family history. It's really something that you'll be glad to have later. Next slide. And as I mentioned, family history is a risk factor for all kinds of diseases throughout all stages of life. And so this is not just for cancer. We can think of in infancy, blood disorders, birth defects. In children, things like asthma and autism. In adolescents, things like diabetes and depression. Adults, that's where we think of cancer and heart disease. And in older adults, that's where we start to think of things like Alzheimer's disease and osteoporosis. So really through all stages of your life, there are certain health conditions that you may be more at risk for based on your family history, and this can be important in multiple regards. Next slide. So when you go to take your family's history, what we talk about always is getting at least a 3-generation pedigree, and I'll show you one in a minute, but basically we want to have your grandparents' generation, your parents' generation, and your generation at a minimum. If you can get more than that and go back a little bit farther, even better. What you want to ask about everybody in the family and record is their age, any diagnosis they've had, so any health problem they've had, and if so, what age were they when they were diagnosed with that health problem, and then their age when they passed away, and their cause of death. You also might want to ask about any major surgery somebody had, and there's reasons for that, and I will describe later. But for example, if somebody had an early hysterectomy due to fibroids, that would have lowered her chances, of course, of later getting an endometrial or an ovarian cancer. And so you need to take that into effect when you're looking at the family history. Any other associated abnormalities, birth defects, anything else that comes up in the family history. You want to also, for both sides of the family, and really for all 4 grandparents, record the ethnic background, your ancestry, and your religious background. And that's because some hereditary cancer syndromes are actually more common in people of certain ethnic groups. For example, hereditary breast ovarian cancer is more common in Ashkenazi Jewish individuals from Germany, Czechoslovakia, Hungary, Poland, Russia area. And so that's important information that your genetic counselor might need when you meet with them. It can change the testing that you might be offered. Next slide. This is a picture of a 3-generation pedigree. So here you can see the grandparents are all shown. And when we draw a pedigree in genetics, we draw circles as women and squares as men. People connected sort of with a horizontal line have had children together. People hanging off the same horizontal line are siblings. And so if you start down with the person with the arrow, we put an arrow at the person who we're talking to. And so our patient, or our proband, we call them. So we're talking to this 35-year-old woman. We know that because it's a circle. And she's not had any cancer yet. She has one 30-year-old sister that you can see on this drawing. And moving up a generation, her parents are both still living. Mom's 65 and dad's 67. Most of the cancer history is on her dad's side of the family, where you can see her dad has a sister shaded in orange who had colon cancer diagnosed at age 40, and she's currently age 62. Moving up another generation to her paternal grandparents, you can see that her paternal grandmother had an endometrial cancer diagnosed at age 49 and died at age 72. And she's written in that the ancestry on her paternal family is German and Polish. Ancestry on the maternal side of the family is English and Irish. And you see there's a diabetes case written in as well. So this is, you can actually draw this up if you like when you're drawing your family history, and just use the convention that circles are women and squares are men, and you want to go back at least those 3 generations. The one thing I would add to make this a more complete 3-generation pedigree is the first cousins. They're in the same generation as our 35-year-old patient, and we really want to see what's happening in the current generation as well. And so that would make this an even better family history. Next slide. This is an example of a family history questionnaire. Before someone comes to see us in cancer genetics, we actually mail them a questionnaire that looks a lot like this. And the things that we have them collect are the names of their relatives, and again, starting with mom and dad, brothers and sisters, children, and then moving out to aunts and uncles and grandparents. And then we would also ask them to include dates of birth if they have them, just to figure out ages. Or you could put current ages, then the type of cancer they've had, if any, and if they've had a cancer, their age at diagnosis, then their date of death if they've passed away, or you could just indicate that they're alive or deceased, and their current age or age at death. That's a little easier than getting exact dates of birth and dates of death. It kind of depends on how involved you want to get. Some people who are really into ancestry already have dates of birth and dates of death, and what they're missing is causes of death and diagnoses, and so they can add that. I think for somebody who doesn't have any of this information, the easiest things to get would be current age or age of death, whether they're living or deceased, whether they've ever had cancer or not, and if so, how old they were when they were diagnosed with their cancer. And we generally have people jot down what hospital the person was treated for their cancer at. That can be helpful if you need to get medical records to confirm a diagnosis, or for a lot of our testing for hereditary colon cancer, particularly Lynch syndrome, we sometimes will start by testing the actual tumor from a patient who's had colon cancer, and that would be stored at the hospital where they underwent their surgery. And so that's a piece of information that might be useful when you come to see us in cancer genetics. Next slide. So when you hit a patient, when you're taking the family history and you find out a relative's had cancer, these are the specific things you want to know about the relatives who've had cancer. Again, their current age or their age at death if they're deceased. You want to know their age at or date of their diagnosis, and again, the age at death like we mentioned. With colon cancer history, you might want to know also things like the number of colon polyps the person had and what type of colon polyps they've had, and that's a little trickier sometimes to find out. The type and location of any cancer they had, and again, the age at diagnosis of that cancer. Whether that's where the cancer started or where the cancer spread. This is a common confusion. Someone will tell me that their aunt died of liver cancer, but it was liver metastases from a colon primary. And so really what we're looking for is where that cancer started, and that is really a colon cancer. Even if the fact that it had spread to the liver and that was her cause of death, it really was a colon cancer that had spread to her liver. And so for risk assessment, we need to know that it was a colon cancer. The hospital where they were treated, like I mentioned, and any major environmental exposure. So for example, if you find out that your aunt had a melanoma, but she was a lifeguard for 20 years, that can possibly explain that diagnosis, and we won't be as concerned that it might be hereditary. Similarly, what just happened? Sorry. If somebody has had a lung cancer and they have a history of cigarette smoking, that could be the cause of that cancer again, and you'd be less concerned about a genetic component. Next slide. If you are talking about a relative who's never had cancer, really what you want is their current age or age of death if they're deceased. You want to know their health status. Maybe they've never had a cancer, but maybe they have diabetes. So any other significant illnesses they've had, and again, age of diagnosis. Any physical findings associated with particular syndromes, and there aren't really any major physical findings associated with the colon cancer syndromes, you know, that you would specifically be looking for. And again, I mentioned before, if they've passed away, the cause of death, and their age of death. Next slide. So I just want to talk about some common things that come up when you take a family history that can cause some confusion. One is that someone will tell you that their relative had a female cancer. And that can be a number of different cancers. That could be cervical cancer, that could be uterine cancer, which we call endometrial cancer in the healthcare field. It's the same thing. Uterine and endometrial are the same. Or it could be an ovarian cancer, and that's really going to change your risk assessment for these particular syndromes. We'd be much more suspicious about a uterine cancer or an ovarian cancer combined with colon cancer than we would about a cervical cancer. So if somebody tells you, oh, she died of a female cancer or she had a female cancer, there's some questions you can ask that might give you a hint as to what kind of cancer it was. So for example, if they tell you it got detected on a pap smear, well, that's likely cervical cancer because that samples cervical cells. If they tell you that they got diagnosed after they were having very, very heavy bleeding, that's likely a uterine or an endometrial cancer, and so that's a common presenting sign for those. If they tell you that the person really didn't have much symptoms, they're kind of sick, a little flu-like symptoms, and they became very bloated, almost looked like they were 6 months pregnant, that's a common way that ovarian cancer can present because it starts to accumulate fluid on the abdomen that's called ascites, but it can look like someone's actually pregnant. You can ask them a little too about how they were treated. If they had a hysterectomy, but their ovaries were left behind, it was probably not ovarian cancer. They would not have left them if that's where the cancer started. If they didn't get any chemotherapy at all, it was probably not ovarian cancer because that's a much more aggressive cancer that's almost always treated with chemotherapy. If they got a LEEP procedure or a colposcopy, those are common treatments for cervical cancer, and so that would be a sign that you might be dealing with a cervical cancer. Next slide. Another common problem with taking a family history is someone will say, well, she died of cancer, but I don't know what kind. It was everywhere by the time they found it. And one of the things that we do in genetics to help people get to the bottom of this is help them get records. And so there's two ways that you can kind of help get this kind of information. So one is that you can request copies of their medical records. And the thing that we think is the most helpful is actually the pathology report. And that's going to be located at the hospital where the person had their surgery. And so you send a signed medical record release, and they will release that information. I do want to point out that if you request that yourself as a family member or as the patient, they usually charge you per page for the records. But if your physician or genetic counselor makes the request, there would not be a charge for the records because it's assumed it's being used for medical purposes. So this is something that if you want to do it, you might want to go in and see a genetic counselor and have them help you release the records so that you can find out what type of cancer without having to pay for the copies. If the family member has passed away, really one of the best ways to find out what kind of cancer they had is to actually get their death certificate. And so there's two ways to do this. The most inexpensive way is to actually get them from your state Department of Health, but a lot of times these are in the capital city of your state, and so you might have to travel pretty far. They could be in different locations depending on the year of birth and year of death, and a little trickier to find and a little more legwork on your side of things. There are also a lot of websites, and I've listed one here. It's actually www.vitalcheck.com. I don't work for them, but they are a really easy way to get death certificates from any of the 50 states. They arrive really quickly by FedEx. It's slightly more expensive, though, so I think it's on the order of $25 to $30 per death certificate. But there's a lot of death certificates that aren't so helpful, but many of them now in the second section have kind of contributing cause, and so it might say colorectal cancer, duration duration 15 years, and you'll know that the person was 75 when they died. So you can surmise from that that they were diagnosed at around age 60. And so this can help you if you have one of these family members who died of cancer, but nobody knows what kind. Next slide. So here are the clues once you get that family history information that you might have a high risk for having a hereditary type of cancer syndrome. So if you see the same cancer in 2 or more close relatives on the same side of the family, that's a red flag. If you see multiple generations affected, so again in that 3-generation pedigree, if there's a cancer in the grandparents, the parents, and your generation, that's a sign that the cancer is more likely to be hereditary. Earlier ages of diagnosis, and the easiest rule of thumb on this is that anything under age 50 is considered an early age of diagnosis, and so that tends to be a little bit more risky for being a hereditary cancer. If you see a rare cancer in the family, for example, with Lynch syndrome, there's an unusual type of skin cancer of the sweat gland called sebaceous skin cancers that you don't see very common outside of Lynch syndrome. And so that on its own sometimes is an indication for seeing if the family might have Lynch syndrome. Another big red flag is if you find one person in the family who's had cancer more than once. So maybe they had a colon cancer at age 40, and then at 47 they had a uterine cancer. Or maybe when they were diagnosed at age 50, they had 2 colon cancers at the same time, or at 2 different times. That's a big red flag that there's an underlying susceptibility. 1 in 3 women will get cancer during their lifetime, 1 in 2 men will get cancer during their lifetime. So all of us could get it once, but when you start getting it more than once, it's a sign that there might be an underlying susceptibility. Similarly, multiple colon polyps. So someone who's had more than 10 colon polyps is a sign that there seems to be a polyp former and maybe there's some susceptibility going on. And then also, these days, a lot of people with colon or uterine cancer, their tumor will actually be screened at the hospital when they're diagnosed, and it'll be screened for 2 features that will tell you whether the person's more or less likely to have Lynch syndrome. So if the person's pathology report mentions that they have abnormal staining for the Lynch syndrome proteins, or that the tumor is something called microsatellite unstable or has MSI. Those are 2 features that would indicate that the family is more likely to have Lynch syndrome and should be seen by cancer genetics. Next slide. So a couple things I want to mention to you, just a cautionary tale about taking family histories. Next slide. So a lot of people just don't know details about their family history. So again, when you're taking the family history, there was a generation that didn't like the C word, and so they didn't talk about the cancer. And so you might not be able to get good information. They might know the specific site. They might know they had cancer, but not what kind of cancer, and that's where getting those records can be helpful. They might know they had cancer, but not know how old they were when they were diagnosed, and that's going to be a limitation. But you can, get a sense for that. If they died at 50 and they had a colon cancer, had they been sick for a while, or was this something that was sudden that came up and they died suddenly? You can get a sense for when they were diagnosed. If sometimes we need to verify the family history just to accurately assess your risks. So if we have a female cancer or a cancer of an unknown type, we'll need to get the records to figure out what kind of cancer. The other thing that's happening over the generations is families are getting smaller, and so it can hide a susceptibility because there just aren't as many at-risk people. The other really kind of good thing is that more and more people are getting colon screening, they're getting their colonoscopies, and they're going to pull out a polyp and stop themselves from getting a cancer. But you can see where that can mask or hide a hereditary colon cancer family, because if people have just gone in very regularly and gotten their colonoscopies and had polyps removed and kept themselves from getting cancer, your family history won't show any cases of cancer, and it's a lot harder to know your family history of polyps. Most people don't know if Uncle Ed had some polyps, and if he did, how many and what kind. And so that's a lot less clear information than knowing if somebody had an actual colon cancer. Next slide. So this shows how things can change. So this is a patient who we took some family history, and she said her mom died of stomach cancer, her sister died at 48 of bone cancer, and her brother was having some prostate problems. If you could advance. After we pulled medical records on this family, we discovered that the sister who had bone cancer really had a breast cancer diagnosed at 45 that spread to her bones, and so she had bone metastases when she died at 48, which is why the family reported bone. But it's really the breast cancer that's the important thing. The brother with prostate problems actually has prostate cancer, and the mother with stomach cancer, on review of her records, we determined that was actually ovarian cancer. And a lot of abdominal organs people just call stomach cancer, and there's a lot of stuff in there. It could be colon, could be pancreas, small bowel, ovary, and so stomach cancers we're always a little wary of unless we've actually seen records, because they often change. And so this family now looks much more suspicious for having hereditary breast ovarian cancer than they did when we took that initial family history. Next slide. Also, your family history can change over time, and so it might not be clear now that there's a hereditary syndrome, but a couple years from now it can be. And so the reason this is important is that a lot of doctors take your family history at your very first visit, and then they never really update it. And so it's important that if your family history changes, you tell your doctor, because it might make what wasn't very high risk before suddenly high risk. And I'll show you an example of that on the next slide. So here's a patient that the first time she was seen and someone took her family history. She was healthy, her brother and sister were healthy, and her mom had had a colon cancer at age 50 that she died from. Well, a couple years later, we can advance the slide. Oh, someone said the sound has been shutting off. Okay, let me know if that's happening and I can call it in. So 2 years later, in this case, we find out that now her sister's been diagnosed with an endometrial cancer, and her brother's had a colon polyps at age 48. So now this family is looking much more suspicious than it did originally, and just showing over time how something can kind of reveal itself. Next slide. One of the things that we think about when a family gets referred in with some colon cancer in the family is we kind of go through a differential diagnosis that's kind of like this little chart that you see here. So one of the things we'll ask is, did the person with colon cancer have more than 10 polyps? And if the answer is no, the things we're really thinking about are Lynch syndrome. So I'm going to talk about that next. There's a couple other possible things, but they're much more rare. If the person did have more than 10 polyps, then we ask ourselves, what kind of polyps were they? And sometimes patients don't know, and so we can help you get your medical records to find out. But if they're an adenoma type polyp, which is the precancerous kind, we often are thinking about familial adenomatous polyposis, or a newer, more recently described condition called MUT-YH associated polyposis. And I'm actually just going to talk briefly about those three syndromes. I'm not going to talk about any of the other syndromes on this slide because they're much more rare, but just keep in mind there are a lot of hereditary colon syndromes, and depending on your family's specific type of polyps, we might be suspicious of something completely different than what I've described here today. Lynch syndrome is by far and away the most common inherited form of colon cancer. It affects 1 out of every 35 colon cancer patients, and so it's certainly the #1 usually on our differential. But you can see there's a whole other kind of polyps called hamartomatous, which have several different syndromes associated with them. Next slide. So Lynch syndrome can be caused by mutations in one of 4 genes. They're pointed out here. MSH2 and 6 are on chromosome 2, MLH1 is on chromosome 3, and PMS2 is on chromosome 7. It also can be caused by problems in the EpCAM gene, which is just right in front of the MSH2 gene on chromosome 2. Familial adenomatous polyposis, which we're going to talk about a little bit today, is located over on chromosome 5. Next slide. The way most of these cancer susceptibility genes work, it advanced 2, if you guys could go back one. The way most inherited cancer susceptibility syndromes work is that everybody has these genes, and they're good genes. You want them to be working. So sometimes I do charades. So those of you who can see the video portion of me, I'll tell my patients, you know, you have 2 copies of every chromosome, and so you have 2 copies of every gene, and each gene codes for something that you need to grow and develop properly. And so these genes are good genes. They're protective genes. Sometimes I describe them like the brakes in the car. As long as they're working, the brakes stay on and the cells grow nice and slowly like they're supposed to, dividing when they should and dying when they should. So when someone is born with a mutation in one of those genes that they inherit from their mom or their dad, that copy with the mutation is going to be in every cell of their body from the day they're born. And so it's sort of like being born one step closer to getting a cancer, because then during their lifetime, at some point when one of their colon cells, or with Lynch syndrome, maybe one of their uterine cells, just by chance acquires a mistake in the other working copy, they now have no more working protective gene. The brakes come off, the cell grows too fast, doesn't die when it should, and that cell becomes the cancer. So in the hereditary families, it's like being born one step closer to developing a cancer because of having that one mutation in every cell of your body from the day you're born. And what we can tell people with gene testing is whether or not they've been born with one of those mutations, but we can't tell you when you'll get the second one during your life and develop a cancer, because that's happening in your body as you're aging, and we can't survey for that. And so we just know that somebody's at increased risk, and that what they're at increased risk for, and so we can screen them. But this is the reason for those characteristics I talked to you about with the earlier ages of diagnosis. If you're one step closer, it's not going to take as long on average. You can see the multiple generations passing it down, clustering of certain cancers like colon and uterine cancer in the case of Lynch syndrome, and multiple primaries, because you could get the second mistake 1 year in a colon and have a colon cancer, successfully treat that, and 8 years later it happens in a uterine cell and you have a uterine or endometrial cancer. So that multiple primary. The sporadic ones I talked about that pop up by chance are usually cases where somebody doesn't have any mutations in their genes that they're born with, but again, we're aging and our cells are dividing, and if one cell accumulates enough mistakes, it can start growing funny and become a cancer. In this case, we tend to see one colon cancer patient in the whole family at a later age of diagnosis, and single tumors, not multiple tumors. Next slide. Most inherited cancer syndromes are inherited in a dominant fashion, with the exception of the mut-YH polyposis, which is recessive. Dominant means that if your mom or dad has Lynch syndrome, remember, they have one mutation that they were born with and one copy that works correctly. So when they have children, they have to give them one of those copies. If they give them the child the copy with the mutation, then that person does have Lynch syndrome and they have the higher risk for getting cancer, and they can pass it on to their children. But it's just as likely that they can give their child the working copy, the one without the mutation. In that case, their child has no increased risk for cancer. They can follow the American Cancer Society guidelines for colon screening, and they can't pass it on to their children. So when I was at Colon Congress Day with colorectal cancer back in March, someone had come up to me and said, you know, we're pretty sure the family has Lynch syndrome. What's the point in doing testing? Well, I think the point is that some of the kids will not have inherited it. And if they don't, they can get a colonoscopy at 50 and go every 10 years, like people in the general public, which is a lot less often than family members who are assuming they have Lynch syndrome, who need to go every 1 to 2 years starting in their 20s. And so this really can change their management in a really positive way. And so finding out that you might not have inherited it is one of the great reasons for doing gene testing. Next slide. So Lynch syndrome causes earlier age of diagnosis, like we talked about. The colon tumors have a tendency to be on what we call the right side of the colon, so in the cecum, ascending colon, or the hepatic flexure, as you can see on this diagram. But it's not a hard, fast rule. We certainly have patients who have rectal cancers who have Lynch syndrome. It's just a little bit more common that they're on the right side. And we can see a lot of other cancers, including endometrial cancer, ovarian, stomach, urinary tract, small bowel, biliary tract, and sebaceous skin tumors. Next slide. There are a couple clinical criteria that if you've taken your family history, you can kind of think about. This one's called the 3-2-1 rule, and it's if you have 3 people in your family with a Lynch syndrome, which is also known as HNPCC, so if you see those words, they can be used interchangeably. Commonly, it's now called Lynch syndrome. So 3 or more relatives with a Lynch syndrome-associated cancer, so we talked about those, colon, ovarian, endometrial, stomach. 2 or more generations affected, so that's the 2. And 1 person has to be diagnosed under age 50. Those are kind of the easiest way to remember these criteria. So that would be a really strong suspicion that the family has Lynch syndrome. Next slide. There's a weaker set of criteria which just is less strict. So anyone with colon under 50 is probably worth evaluating for Lynch syndrome. Anyone who's had more than 1 colon cancer at the same time or at 2 different times in their life, and that also includes someone who had colon cancer and another Lynch syndrome associated cancer, regardless of their age of diagnosis. Individuals who have colon cancer who have a close relative, so this would be a parent, sibling, or child, with a Lynch syndrome associated cancer if either of the two are diagnosed under age 50. And then this also includes 3 cases of colon or Lynch syndrome associated cancers total in the family, regardless of age of family history, age of diagnosis. Next slide. Here's the cancer risks for Lynch syndrome, and they're significantly elevated, as you can see, compared to the general public. And again, this is why testing kids is important, because the ones who inherit it have the high risks and need increased screening. The ones who don't inherit it move down to the general population risk and can follow the ACS guidelines. Next slide. Screening guidelines are colonoscopy every 1 to 2 years, starting around age 20 to 25. If you have a mutation in the higher risk genes, which are MLH1 or MSH2, or starting around age 25 to 30 if you have a mutation in one of the lower risk genes, which are MSH6 and PMS2. And we're still recommending endometrial biopsies annually starting in the 30s, but there's not a lot of evidence that this actually affects outcomes, because people tend to get diagnosed with endometrial cancers pretty early and do well. But I'll talk to you in a minute about what most of my female patients with Lynch syndrome are doing. Again, urinalysis is something that is still included in some of the guidelines, but there has been a study not showing that it was very effective in Lynch syndrome families. It's easy, it's not invasive, it's inexpensive, so we're still recommending it every 1 to 2 years starting in the 30s. And a good history every year. Some people also now add an upper GI endoscopy to look at the stomach every few years, but that's controversial at this point too, because the stomach cancer risk is not that high. Next slide. Just a family history I wanted to talk to you about. This is a 90-year-old gentleman who was having a colon cancer at age 90. He had had a colon cancer previously at age 83 and had reported that he had had multiple skin cancers over the years. He has not much family history of colon cancer related type things. He had a brother die at 49 of lymphoma, a mom who had a breast cancer in her 70s who died at 96, and a father who had a prostate cancer in his 70s. But we do routine screening for Lynch syndrome at our hospital, and so when he was diagnosed at 90, he had the staining for the Lynch syndrome proteins, and it was found that he was missing the MSH6 protein. So he was referred to genetics. We counseled him and ordered MSH6 gene testing, and he in fact had an MSH6 mutation and has Lynch syndrome. And he really doesn't meet any of those criteria we just looked at. He's certainly well over age 50. But this is important for his son and his grandchildren. I also dug a little more into his skin cancers and found out that in addition to his squamous cell and basal cell carcinomas, he had had about 4 sebaceous adenomas, those sweat gland tumors, over the years. And so it became a little bit more consistent with his diagnosis of Lynch syndrome. Next slide. This is a patient with a much more obvious history of Lynch syndrome. Can we advance to the next slide? This is a woman who, sorry, it went twice again, who had 6 primary colon cancers over her life. She started with her first colon cancer at age 33, and I don't know how she had any colon left, but at age 83 we caught her when she had her 6th primary colon cancer. Along the way she had had a uterine cancer and a kidney cancer as well. Again, because we do routine screening at the time of diagnosis, we picked up that her tumor was missing MSH2 and MSH6, and she was seen for genetic counseling and genetic testing. And we did find that she had an MSH2 mutation and had Lynch syndrome. The reason I bring her up is that had she been picked up earlier, like after her first diagnosis at age 33, perhaps her son could have prevented getting colon cancer. He, in the meanwhile, got colon cancer in his 30s and died from it at age 56. And so I feel like, you know, even in an obvious case like this, not everybody gets referred. And so it's important to advocate for yourself. If you've got multiple primaries, you know, you might want to see cancer genetics regardless of whether your doctor mentions it to you or not, because you have some red flags in your family that the history could be hereditary. Also, this very early age of diagnosis was a big red flag. Next slide.
Heather, this is Andy. Just a quick question. I want to do a real-time question that it's what was presented. There was a person that said that they were diagnosed at stage 3 with colorectal cancer in their 20s. Was a change to genetic stage 3 reoccurrence now in 30s. would a change, ultimately, would a change in diagnostics or something else be responsible for the difference in diagnostics between sporadic versus genetic diagnosis?
So I didn't really catch the question there, Andy. Could you repeat it? So I understand this is someone who had a colon cancer in their 20s and then a recurrence in their 30s. And are they the only person? I still think just because based on early age of diagnosis, that's somebody I would want to see in cancer genetics, frankly. Even if they don't have any family history, that age is so young that it's a red flag. And so I would be interested in seeing that patient to see if it could be hereditary. Was there another piece of information I'm missing, Andy?
I think for right now, that's good.
Okay.
The other quick question before we said is that you mentioned that can you hear me real quick and then we'll get going?
I can.
You mentioned that certain cancers are, you mentioned that certain cancers are associated with families from specific regions or religious. Is Lynch syndrome seen more often in people of a certain heritage? And we'll cease questions after this to let you continue on.
Yeah, so great question. So certain mutations are seen more commonly in certain ethnic groups in Lynch syndrome. So for example, everyone from Newfoundland, Canada, who has Lynch syndrome has the same mutation. It's this common MSH2 mutation. And so if you're from Newfoundland, or your relatives or ancestors were, I could just test you for that one mutation and probably pick it up without doing more expensive testing of the whole gene or multiple genes. And so that's an interesting thing. There is a mutation in MSH2 that's more common in Ashkenazi Jewish families. So if the family's Jewish, still most people do full testing because it doesn't account for all of the mutations, but it is the more common mutation. We've reported on something we call the American founder mutation, and it's a large deletion in MSH2 of exons 1 to 6, and it's just a recurrent mutation found in the United States, never seen in Europe. We've been doing some genealogy trying to trace it back and figure out who the initial ancestor was. We got back so far, we're starting to wonder if it could have come originally from Native Americans, because we really can't find it in Europe, and you would have thought some people would have been left behind. So there are, I wouldn't say it's more frequent in any certain ethnic group, but certain ethnic groups might have a specific mutation. Okay, and we are so running out of time, so I'm going to just kind of do some quick things on the next couple of slides. So just to briefly mention the polyposis syndromes, they're much easier to diagnose. If you have more than 10 adenomas, it is concerning that you have a polyposis syndrome and you should come see genetics. So if you guys can keep advancing. They're due to completely different genes than the Lynch syndrome genes, but testing is available and it has a good chance of picking it up. And I do want to mention that with the polyposis, you may not have any family history. 30% of the time, people with FAP are the first person in their family to get it. It's what we call de novo. So the mutation occurred in the egg or the sperm that made them. It was not something their mom or dad had, so there's no other family history, and it pops up new. But once it's popped up, then it does move to the children with the 50-50 risk, so it's important to get it diagnosed. Next slide. The other one, the other polyposis syndrome, keep going, and here you just see very early ages of polyps and cancers with FAP. There's a weaker form, but you would pick that up with more than 10 polyps. Mut-YH-associated polyposis has been diagnosed more recently. The only thing unusual about it is it's recessive, sort of like cystic fibrosis. So your mom has to carry a mutation, your dad has to carry a mutation, and if you get both of them, then you have a higher risk for making colon polyps and colon cancer. Again, you might not have any family history in this case because they're carriers, and carriers, we're not sure whether they have any increased risk. And here you can see a couple mutations that are more common in Europeans, in Caucasians from Western Europe ancestry, and a different mutation that's more common if you're Eastern Indian family. So again, just that ethnicity piece. Next slide. Just go ahead and advance 2 for me. And just keep in mind that if there's more than 10 polyps of the adenoma type, or really any type, you might want to see cancer genetics. Advance again, please. And again. So as we run out of time here, I just want to mention to you guys that you might be listening to this and thinking, well, I don't think I have Lynch syndrome, and I don't think I've got FAP, but there's there's still 2 cases of colon cancer in my family, or maybe there's 1 case, and that could be those familial clusters I mentioned. And so these are families we consider moderate risk families. And so there's 1 or 2 cases in the family. You don't necessarily need to see genetic counseling, although we're happy to see you just to make sure you don't fall into that high risk group. And you do need increased screening in these cases because your family members, again, may share some of those minor genes, they share environmental exposure, so they can have a slightly increased risk. The general rule of thumb is that if you have a close relative, a parent, sibling, or child who has cancer, colon cancer, your risk is about double that of somebody without that history. Next slide. You've heard me refer a little bit to degree of relatedness here. And so the closer the relative is to you with colon cancer, the higher your risk. If you guys could advance the slide, please. So this is just a picture of, sorry, you went too forward. Slide advancing is not working very well. Here's a picture of a woman again with the arrow, and you see her first degree relatives have a 1 in them. So that's brothers and sisters, children, and parents. If you have one of these relatives affected with colon cancer, that does the most to increase your risk. Then you move out to 2nd degree relatives, and that includes aunts and uncles and grandparents. That slightly increases your risk, but nowhere near as much as having a 1st degree relative. Beyond that, we get to 3rd degree relatives like first cousins, great aunts, grandchildren, great-grandchildren actually. And so that's going to, with a 3rd degree relative, your risk is almost back to the general population because they're too distant to increase your risk. Next slide. This is good that we're doing this in a webinar because this slide is impossible to see on the screen when I give talks, but there's a really great paper I've got listed down at the bottom. This is out of Utah. They have a great population database there. So they looked at what your risk was for getting colon cancer depending on how many relatives you have with colon cancer. So if you see table 1 on the top left, that's the number of affected 1st degree relatives that you have. My slides have just gone away for me. Are they still there for you guys? Okay, I'm just getting word, guys, that Andy has a tornado on the ground where she is and had to go to the basement. I believe she's trying to turn things over, hopefully to Michael, who is probably trying to fix things right now. Michael, if you're in control, if you could advance 1 more slide. Okay, we can stop here. So you guys can look at that last slide and kind of figure out, but basically if you have a close relative, your risk doubles. The general population risk for colon cancer in the United States is 5%. So if you're at double that, you're around 10%. Nowhere near as high as that 50 to 85% we saw with Lynch syndrome, but certainly increased, and so you would do increased screening. So this is the NCCN guidelines now, depending on your family history. So if you have a 1st degree relative diagnosed under age 50, or 2 1st degree relatives diagnosed at any age, they want you to do your colonoscopies every 3 to 5 years beginning at age 40, or 10 years before the earliest diagnosis of colon cancer in the family. So if somebody was diagnosed at 45, their relatives actually have to start at 35 because we want to start 10 years prior because we think it takes about 10 years for a colon polyp to become a colon cancer. So if that person had had a colonoscopy at 35, we maybe could have stopped their colon cancer that they got diagnosed with at 45. So again, if somebody's got a 1st degree relative diagnosed under age 50, their close relatives, 1st degree relatives, need to start colonoscopy at 40 or 10 years younger than the earliest diagnosis and do it every 3 to 5 years. If that close relative was diagnosed at or after age 50, last slide, then you could do your colonoscopy every 5 years. Okay, so it doesn't sound like they're going to be able to back up for me. This is another tool that but you guys can look at the slides. Here you go. So colonoscopy every 5 years beginning at age 50, or again 10 years earlier than the earliest diagnosis. So if your relative was 55, you need to start at 45 and you would go every 5 years. If you have a 2nd degree relative, so a grandparent diagnosed under age 50, you start your colonoscopies at 50 and then repeat them depending on the findings. And so if they find polyps, it's going to be more frequently than if they don't find them, and then they'll stretch it out. If you have a close relative who hasn't had colon cancer, but they had a really nasty polyp that was almost a cancer, you still might start your colonoscopies at age 50 and repeat them maybe a little more often depending on what you find. Otherwise, if you have less family history, so if you have a grandparent diagnosed at 60, you just follow the average risk recommendations for the general population, which is colonoscopy every 10 years starting at age 50. Next slide. This is another tool that's online that you can use to enter your family history, and it actually provides a risk assessment. So it'll tell you whether you're at high risk, moderate risk, or average risk based on your family history. And it does both cancer and cardiovascular disease. So that's a tool that we have available here at OSU. Next slide. So I just want to briefly, because we're way over, tell you that if you, and we started late and the slides have been causing problems and Andy has a tornado, but at any rate, if you are concerned that you might have a family history, I would encourage you to get a genetic counseling appointment with a local genetic counselor. If they think that genetic testing is appropriate, what we like to do then is test one of your relatives who's had a cancer first. The testing is a little more informative in that way. The costs can be anywhere from $500 to $4,500 to do all of the genes, but insurance coverage is quite good if your family history meets these criteria that we've talked about today. And once you find a mutation in the family, you can be tested simply for that exact mutation, which is much less expensive, around $200 to $500, and very reliable at that point for the relatives. And so what they'll do is kind of describe to you the process, the risk, benefits, and limitations of doing the test, and help you decide whether you want to be tested or not, and if so, coordinate that testing and get you your results. And if we can just move all the way down, guys, to slide 54, I do want to mention there is now a law in place called GINA, the Genetic Information Non-Discrimination Act, which prevents you having any problem with health insurance or employment based on a genetic test result. So the only loopholes are life insurance, disability insurance, and long-term care insurance. So I have had some young, unaffected relatives who opted to get their life insurance in place before they do their genetic testing. No reports of people really having any trouble with this, but there is no law preventing them, so some people, just to be on the safe side, would do that. And to keep forwarding, guys. So just wanted to tell you guys in slide 55 when we get there. Advance again, advance again, advance again. There's the GINA law, advance one more time. So to find a local genetic counselor near you, there are two websites here. One is the National Society of Genetic Counselors. You can put in your zip code or your city. Choose cancer from the specialty, and then it will give you a list of cancer genetic counselors near you. There's another website available from the National Cancer Institute that lists cancer genetics experts specifically again, and you can look by region. If you can't find a cancer genetic counselor near you, there's actually now a national telecounseling service that will do telephone genetic counseling. And so it's much easier to get cancer genetic counseling now no matter where you live, whether there's someone conveniently located near you that you can go see or somebody who can do this with you over the phone. Next slide. Feel free, everybody, to call or email me anytime. My information's on the next slide, and there is a link to that family health link questionnaire that we have. And I think that we were going to have a slide with resources. I'm not sure if that one's coming up.
Yeah, we're going to put it out on the website.
Email?
Yeah, and send it out with the email that's going to go out to everybody, and at the end of the session. Heather, I'm sorry we had some technical difficulties, but the material was A+, and I really appreciate you not having a tornado come through.
Yeah, that would have been a real disaster.
Because
I hope Andy is all right.
I was going to say, because this is a day of first for us, not only some new intros and slides, but having the webcam on and you being able to present. It was very it was exciting.
Yeah, it's very high tech. Michael, I was going to tell you if we want to retape it before we make it available to people who missed it today, so I can get through all of it. That would be great.
Sure, we'll take a look at the schedules. But yeah, everybody at this point, we'll put out as much as we can. The slide deck will be available on our SlideShare application online, and the Fight Colorectal Cancer /webinars link is where you'll find information on this and all the others. So I know there were some pre-asked questions, which unfortunately Andy has access to, but we'll get them responded because we have everybody's email who sent those questions in, and oh wait, hang on, I got one more slide. There it is. That's Heather's information with regards to direct contacts if you want to get a hold of her, and we'll again.
Absolutely. You can send me any questions this way. You know, if we have some other ones, I could make a little Q&A for when we send out stuff afterwards. And that's that online tool. But there were a couple other resources that they're going to be emailing you about: fact sheets about Lynch syndrome and about FAP, a nice sheet that you can use to fill out for each of your relatives when you're taking your family history. There's a great family health history tool that we worked on together with Fight Colorectal Cancer that you can use. There's a lot of great tools available, including the Surgeon General's health history tool that we gave you the link for earlier, just to make it easier on you.
Awesome. And we did post a couple of those in the chats for people to see, and we'll have a compiled list once we get the session all wrapped up. So I know we're out of time. Heather, thank you again so much. We appreciate you having you on our webinar series. You're always always chock full of info. We love that. And thank you.
Thank
you,
you,
everybody.
Bye-bye.
Bye-bye.